So I'd like to welcome everyone around the world today for this webinar, and we literally have people joining pretty much in all time zones. So I apologise for those people whose time zone isn't so kind. Joining me today as a special guest presenter, I'd like to introduce and welcome my great friend and colleague, Chris Hillier. Chris is the Executive Director of Innovation at the new Hanover Regional Medical Center in Wilmington, North Carolina. And Chris and I have been working for the past 15 months or so on a digital human cardiac coach project called Hannah. So I'll just briefly pass to Chris to say hello, and then we'll pick up on the rest of the webinar.
Thanks very much, Mary, and thank you everyone that's, I don't think you say called in, do you, when it's on the internet? So everyone who's registered for the webinar, I'm looking forward to sharing with you the work that Mary's really been guiding us through for the last over a year now. Thank you for your time. Okay,
thank you, Chris. The webinar today goes for about 90 minutes, and I'll speak for about 45, 50 minutes. And then Chris will speak for about 25 minutes or so. And then Chris and I are going to have a bit of a discussion about what the future might look like and parts of it that are actually here. So the presentation I'm giving today is not a keynote style presentation, but rather a deep dive lecture style presentation through the background and methodology of the AI digital human cardiac coach, so that people will understand the materials when these are released in a couple of days' time. This webinar is being recorded, and the presentation and all materials will be released on GitHub in the following days. So keep an eye out on LinkedIn and Twitter. So this is our experience and perspective from the hospital bed looking up and out. And if anyone says to us they have a new tech thing or have done user testing, we can see through the marketing hype and pretty quickly form a view about what's real. We say to people, and you'll hear it in this presentation, be on our journey over the long term and witness the suffering, because from this there is innovation. What I'm sharing today in this webinar and giving away is a Centre for Digital Business IP and R&D on the digital human cardiac coach and digital human health coach more broadly. This is our IP and hasn't been licensed to anyone else. I will share our discoveries on the common patterns of conversations in chronic disease and disability, and the impact of health illiteracy on service delivery, and the lack of understanding of health illiteracy on service design, and how health illiteracy also impacts current machine learning approaches. And from this, we documented the digital human health coach model for creating AI-powered natural contextual conversations applicable across pretty much all health domains. I will show various use cases today, but starting out, I would like to emphasize that the purpose of the digital human cardiac coach is not diagnosis and treatment. The digital human cardiac coach helps people navigate information, education relevant to the various stages of a person's heart health journey. A new digital capability focused on health illiteracy and what I call high performance accessibility. This presentation is technology neutral. We started the work decades ago, and it is future focused for the decades ahead. So why are we giving all this away? Getting to this point has taken years of hard work. Alan, my husband, who you'll see in this presentation, his health is often fragile, and there have been many times when he has had to down tools on his part of the project while he's in hospital and then recovering. As his carer, my focus has to change during these difficult times. The current COVID-19 pandemic has prematurely ended the lives of many heart patients. We would like to continue our development work, but we started the project with the objective of helping others, and there's a dire need right now. We hope that we can accelerate this process by democratising the body of knowledge that we have developed. And for the first time, We believe this is a body of knowledge that describes the way to address the impact of health illiteracy on machine learning. Just a disclaimer for you to read a bit later, just restating that this is our IP, which we are giving away, and we would encourage people to apply all their skill and due diligence in reading through the materials and applying that in due course. So just a few words about us, and our experience is somewhat of a unique intersection of professional experience and lived experience. And we wanted to frame this discussion about the work that we had done over the past several decades. So firstly, from professional experience, Alan, my co-founder in all of this, is a former Royal Australian Air Force aeronautical engineer with a research background in expert systems. He has extensive technology experience, including systems integration, including in health in Australia and internationally. And you'll also see that he is a qualified fitness instructor, a lecturer, and advocate on cardiac rehabilitation. He has undergone 4 heart surgeries, including 2 bypass surgeries, all up 8 cardiac bypass grafts and 4 stents, and surgeries in the United States when we lived there and in Australia. My own experience covers public and private sector in Australia and internationally, in roles including large-scale government service delivery operations and Microsoft's worldwide public services and e-government business in Seattle. I've been a Chief Information Officer and a Chief Technology Architect. Interestingly, in my early career, I worked in intelligence. And so throughout this presentation, you'll see reference to the notion of common patterns. And we combined this intelligence concept with the concepts around expert systems and other aspects of our professional and lived experience to develop this digital human body of knowledge for health. We know it works. Alan's living proof. I'm going to start by talking about Nadia for a few minutes, and then I'll give you a deep dive into the digital human cardiac coach and the methods that we have developed. Nadia was the first AI-powered digital human for service delivery, co-designed by people with disability. And Nadia was a concept that I developed and I led the project. The challenge that we had was, how do people with disability of all types express themselves in seeking to find and understand information and services? Only co-design could answer that. But let's have a look at the traditional digital approach over the past 20 years around the world. The approach to online and digital by governments and healthcare has been thousands and thousands of forms in PDF and Word, all described in beautiful bureaucratic language, nested in a nightmare maze of websites and portals. So think about what this means for people with disability and the many millions of people who are functionally illiterate. My question has been, why do people have to adapt to systems? We need to change the approach to systems adapting to people. In December 2014, I started the work on an avatar omni-channel concept that would eventually become Nadia. And this started out as a human rights issue well before any of the technology was brought together. The UN Convention on the Rights of Persons with Disabilities is remarkable drafting. It calls out the freedom of expression and access to information by accepting and facilitating augmentative and alternative communication so that people with disability can receive and impart information and ideas on an equal basis. So it seems to me that we haven't got this right. In government and healthcare, much of our community is underserved and effectively excluded, not because of our own capabilities, but because the industrialised model doesn't accommodate the individual and their human rights. So this led to my discussions with Sir Tim Berners-Lee on the concept of Nadia and to understand his work on the human accessible web. So Nadia was grounded in human rights, and we used that to prize open design processes that for a long time had effectively excluded people with disability. Nadia is a phenomenal example of co-design, a deaf-blind colleague doing a PhD in haptic communication, a disability advocate running a social media platform, a young man with cerebral palsy, an Apple ambassador, people with intellectual disability supported by a university psychology faculty in actively participating in co-design. Co-design which revealed insights not otherwise discernible. And here we see a coloured crayon drawing, itself co-designed by people with disability, including people with intellectual disability, of the experience they wanted, a face and a simple conversation using ordinary words. We did not start out with a system design diagram. This was about understanding the human experience. And so after 12 months of rapid co-design iteration, from that coloured crayon drawing to the complete working Nadia digital system with 10,000 questions. Every day we ask, explain, analyse, understand and create. AI's role is to help everyone, regardless of capability, to perform these basic communications and cognitive functions with dignity on an equal basis. So literacy, cognitive ability and accessibility are key design determinants. And here are some pictures of history in the making. The first time a human realistic avatar was meshed with the IBM Watson cognitive platform for the purposes of service delivery. And remember, it was people with disability who imagined that. So with the background on the impact of bureaucratic information on service delivery and for people with disability, let's look at the common themes and patterns of the impact of health illiteracy on cardiac vascular disease and how co-designed AI-powered digital humans can help. What happens when more than a third of the population of the biggest economy in the world is health illiterate, and almost 70 million Americans suffer from cardiovascular disease? Each year, more than 780,000 Americans suffer a new heart attack, and only about 30% attend rehab. And the figures for Australia are about the same. And during COVID-19, cardiac rehab services around the world have effectively stopped. In Australia, almost 60% of adults have inadequate health literacy. That is, unable to understand and apply health information, unable to complete healthcare forms. People cannot read basic text and instructions. Health illiterate populations with a reading level of grade 5 and below. And yet healthcare information is still produced at grade 10 level and up to college grade. A great majority of the population simply cannot comprehend the reading material and do not have the basic numeracy skills that is so essential for their health. Booklets, information sheets, websites written in complex bureaucratic language that people cannot understand. And yet, notwithstanding the massive investments, there is massive underservicing. In the US, more than $29 billion per year in CVD health costs annually is attributable to poor health literacy. Simplifying websites does not overcome the fact that a great majority of the population cannot comprehend the written material and do not have the basic numeracy skills that are so essential to their health. And notwithstanding our own skills and experience, at the beginning of Alan's journey, we were both desperately health illiterate. If we struggled, how could anyone survive physically and mentally? And it struck me that our experience struggling with bureaucratic health information, not understanding it, with no one to talk to when we were most vulnerable, was in many ways the same isolating, traumatizing experience suffered by people with disability. So very simply, what if we could find a way for people to access and understand cardiac health information and ask questions without fear of judgment or stigma? And this is the AI-powered digital human cardiac coach. And given the significant impact of health illiteracy and the high percentage, that is 60% of cardiac secondary events, a person's life journey must be understood, not just the cliff, which is the day of discharge and the following weeks. I'll come back to this visual illustration throughout the presentation. And just juxtaposed against this concept of the life journey are health system processes that can readily be documented in a flowchart such as this. And what we have done here is to map the impact of health illiteracy at different points of the health system processes and traditional approaches used, such as brochures, websites, etc. And what I keep emphasising is the emotional journey of the patient. The human experience is not such a neat map. Co-design reveals the risks, which is pertinent to downstream processes and health outcomes. Imagine just after 1 hour lectures on their conditions, smoking cessation, diet, exercise, and importantly, medications. Patients are left to their own devices to change their lifestyle. Most don't. Many soon stop taking their meds. Many fall off the cliff when they have finished rehab. And the psychological impact on patients and their families is enormous. Research has shown that many health professionals overestimate the literacy of their patients. And so advice is not understood and not sustainable. What is needed is ongoing coaching and the ability for patients to ask questions at any time with answers they can understand. What are the questions that people ask throughout their life journey? How are these expressed? In the corpus I'll walk through shortly, we have documented thousands of these questions from the patient's perspective over 14 years. So how many hours does it take for a person to manage their health? In an everyday, this is what it looks like. This is not only our experience. Co-design reveals the messiness of the human experience, and the reason why this matters is that it is not possible to build a corpus without understanding this. And women and people with disability are underserved and health outcomes impacted. What are the questions that women ask or don't ask, and why? I'll keep emphasising that the unstructured approach to building a corpus does not work, and why co-design is necessary for AI. So how did we get there to create Nadia and the digital human cardiac coach? What does it take to create systems that are more like people? This is an endeavour which is governed by co-design. So for all digital humans, this is the starting point. It is the brand or the purpose, and co-design is necessary to determine the context and the embodiment in alignment with the purpose. This is not just about picking out a face. Nadia's personality was co-designed with people with disability, including people with intellectual disability and psychologists. We had personality design workshops. Imagine this new role, a digital human personality designer. Nadia's personality was designed to be warm, informative and calm, and the digital human health coach would have a similar personality profile. But you could imagine a digital human personality for Nike, for example, being a bit more energetic. So the layers of embodiment really describe the domain knowledge, the look, the mannerisms, the voice, and the layers of context. This is about the community, the industry, the policy settings and the use cases. And these combine to reflect the personality and the brand. So co-design is essential. This is not an IT function. Similarly, the operational model of the digital human is not an IT function. And I'll be covering this in a bit more detail in the coming slides when I start talking about the step-by-step processes for creating digital human conversations. The operational model is a governance mechanism that orchestrates the update of policy or new information, training and feedback. The operational model needs to be considered upfront, even for a pilot, and this will evolve over time. So Nadia was, if we call it, an ab initio creation of a digital human. It was something new, but this is just one of 4 potential pathways to a digital human. Creating a digital human, copying a digital human where the face of a digital human which is used elsewhere is used again, evolving a digital human by giving it different functions, and digitally cloning a real human. And we've seen an example of Deepak Chopra recently, who created a digital clone of himself. So upfront consideration of the brand and purpose and the personality is essential, and that will determine the most appropriate pathway for that particular organisation or brand influencer. Imagine if your digital human face for cardiac, for example, was the same face reused from Domino's pizzas. That wouldn't be brand alignment on that purpose. And from a co-design perspective, it's critically important to consider the persona of the digital human, including the look, to reflect the community served. Don't always go for the young female personas because that's what's available. So we're going to step back and look at the whole life cycle now that we have thought about the brand and the personality and the role of this particular digital human. We need to understand the life cycle from conception, if you like, right through to evolution. And through each stage of this life cycle, there are patterns of conversations that evolve through co-design. So you can think of this similar to a new staff member starting out as a trainee with limited knowledge, and over time develop further knowledge and expertise. In the Digital Human Hannah project, and Chris might speak about this, it was really important planning discussion. What would Hannah's next skill or conversation be? And how would this link in with the operational processes of the hospital? So the training of a real human and a digital human both require an operational model. Another way to look at this is that over time, the interactions between a digital human and a real human customer or patient embed the brand or the purpose by evolving these roles into relationships. For example, a digital human with the role of an assistant may very well over time become a personal assistant. And when we think about Nadia, the people with disability who designed Nadia said they wanted their very own personal digital human assistant to help navigate and make their way through all the complexity. And that's our vision for the digital human cardiac coach. And if we look across industries, there are many different digital human roles, and we see common patterns of conversational models. These common patterns are accelerators or replication. A digital human service manager in the telco industry, for example, or utilities would use common patterns, but with different content. A conversation about the connection to services, for example. A conversation with the digital human cardiac coach on medications in an inpatient setting would be the same conversation pattern as with having a conversation with a pharmacist. I want to introduce the concept of guided conversations that we have developed as a mechanism to literally guide people through conversationally a particular topic, and for these conversations to be able to be repeated as often as the patient needs to build their confidence and understanding. Once again, I'll refer people to the detailed documentation when the material is released on GitHub. In AI systems development, there is much focus on the development of large sets of questions and answers. And to this we say, this is not enough. What if a patient doesn't know what question to ask, or doesn't even understand, or have any knowledge of key concepts, such as volume? And this is the case given the extent of health illiteracy across populations. This is common in any service delivery setting. Machine learning cannot learn what the patient doesn't know, or what populations do not know or do not talk about, given the extent of health illiteracy. And similarly, machine learning on large data sets from health illiterate populations will have gaps and errors. Crowdsourcing fails with health illiterate populations. Similarly, crowdsourcing from experts or sophisticated users, which we are seeing with some of the COVID chatbots and apps at present, also fails health illiterate populations. And I'll come back to this point. Or what if there is further situational context that is needed? A point answer to a point question will not be sufficient. In this example here, we see a patient asking a question about when they can drive. But from a health outcomes perspective, there is a broader conversation about rehab, which will be essential to address further context about driving and other things. So we have developed the approach of guided conversations that takes away the need for the patients to know what questions to ask and for the AI to identify what the patient needs to know. To do this, we sampled tens of thousands of utterances, which are patient concerns and questions, from multiple sources over many years. The raw questions actual patients and their families asked. And we followed a similar approach with the development of the corpus venaria, raw questions, including questions from people with intellectual disability. So sourcing questions from a handful of experts, to be honest, in the case of some of these COVID chatbots, does not cut it. And it has long been the case that authoritative sources don't make the information more intelligible. So this is where the operational model for the digital human health coach is actually critical. The guided conversations is an active process of information transference covering specific topics. Q&A conversations are more passive conversations, but together, guided conversations and Q&A conversations can work together with a question triggering a guided conversation if required. And the documentation we'll put onto GitHub goes into some detail as to the design principles, word variations, synonyms, and so forth. Once again, we do not believe that machine learning can do this ungoverned and without co-design. So back to the concept of the patient journey and truly understanding it as a map from which we develop the corpus. So the questions that people ask and the information they need varies throughout their life journey. And this is why general crowdsourcing from health illiterate populations and from experts fails. A lack of understanding driven by health illiteracy causes unnecessary interactions with the health system. So imagine being discharged with 10 medications and not understanding or even being able to read the label on day one of the cliff. What do you do? Given the significant impact of health illiteracy and the high percentage, that is 60% of cardiac secondary events, a person's lifetime journey must be understood, not just the cliff, the day of discharge and the following weeks. The Boston University Medical Center Virtual Nurse Program did phenomenal work in estimating that hospital discharge typically lasts less than 8 minutes, intended to transform a patient from a completely passive recipients of care when they are at their most traumatized and vulnerable to being completely responsible for all aspects of their own health. The average patient is discharged with 10 medications and follow-up appointments. The Boston University research considers that discharge is even more hazardous with patients who are health illiterate, which is clearly a big proportion of discharge events. The intervention of the industrialized model of cardiac rehab during this hazardous period is not even universally available, and yet rehab and support is required throughout life. And as we have seen during COVID, cardiac rehab is not available at all. So you survived the surgery, which is great. Now our communication and your illiteracy will kill you. The industrialized model of cardiac rehab is a rationed model, a few hours per week for 6 weeks here in Australia, or in some countries, a couple of months. A model where health illiteracy massively impacts cardiovascular disease outcomes. The industrialized model sees massive duplication of common material by thousands of cardiac rehab programs around the world. The booklets, information sheets and websites that people cannot understand. So the one size that fits some offered in the group cardiac rehab programs lacks the essential component of an effective prevention or rehabilitation program, and that is persistent reinforcement and ongoing support, whole of life support at any time, not just a few hours per week for 6 weeks and then nothing. But there is another way. Imagine lifelong support, not just the 12 weeks of rehab. Imagine being able to interact with rehab lessons at any time and ask questions over and over again. Imagine a conversation with your digital human health coach being triggered by sensors in the home. Hey Al, have you weighed yourself today? Imagine help at any time with the identification and explanation of an information sheet or the identification of a medication label via webcam. So the approach and the structure we put around the development of the corpus and guided conversations was to document what we have identified as themes and topics across the patient journey through guided conversations that takes away the need for patients to know what questions to ask. As I mentioned, we have sampled tens of thousands of utterances from multiple sources over the years. Here we see the theme cardiac rehab and the topic rehab awareness. And under the theme heart failure is the topic daily weighing. One reason why it's important to take the structured approach to the development of the corpus is to take the randomness out of content curation and to avoid gaps in priority topic areas. Themes are largely logical groupings of patient intents, largely based on the traditional cardiac lifestyle events and educational sessions. The sequencing of the topics works to address the barriers, including health illiteracy and attitudes regarding compliance with recommended recovery, medication, and lifestyle regimes. Here we see the theme cardiac rehab and the composite topics through which a guided conversation is structured. Breaking this example down further, we see that for the theme of cardiac rehab, topics and a sample number of intents for each topic. Again, emphasising these intents have been discerned from many thousands of patient questions, many clearly impacted by health illiteracy, and also from research undertaken with global cardiac education and research resources. Each guided conversation can be structured to drive benefits in specific areas, such as improving patient heart health awareness, reducing readmission penalties, etc. What we also see here is that in addition to the conversation, there are potentially other capabilities that can be inserted to augment the digital human guided conversation, such as machine vision, for example, and I'll walk through examples of this shortly and how this is done and the benefits it will bring. Given the indicative set of themes and topics for guided conversations we have just looked at, I want to say a few words here about how to go about prioritisation. Again, this is a health outcomes-led discussion, not a tech-led discussion. And this is an example of worksheets that we'll be providing on GitHub. To go through a structured approach for determining the priority of particular conversations, including, for example, who is the owner of a particular conversation. This helps decide where to start. The first few conversations and use cases should avoid unnecessary complexity, including, for example, when and if to integrate with an electronic health record. So co-design brings together the patient and the practitioner view. The problem with the patient-led approach only is that they don't know what they don't know through health illiteracy. And the problem with a practitioner-led approach only is knowing how to communicate with health illiterate patients. Material and concepts are mostly beyond patients' comprehension. And there is quite extensive research on this. Co-design combines both of these perspectives at the beginning of the process. In this example, designing a guided conversation on heart failure. And this is in fact one that we have already done. From the practitioner view, there are specific information transference and health outcomes objectives of this conversation. The risks to be understood, the enablers. Does the patient even have the equipment? And what are we assuming that the patient actually understands or even has the physical means to do? From the patient's perspective, what are the questions that they will ask or not ask? An important activity at this point in co-design is defining the analytics requirements. In the digital human conversations, will reveal insights not otherwise discernible. What the transcript and analytics of the conversation interaction will show between the patient and the digital human cardiac coach is the extent to which the intent is discerned or matched. The structure of the conversation means that intent can be discerned throughout the thread of the conversation, not just capturing yes and no responses. This is important for follow-up interventions and support by health professionals to assist with training and other improvements. and it also establishes analytics to support litigation defence. So continuing the heart failure conversation example, here we see Table A, completed from co-design, shown in the previous slide, which brought together the practitioner and the patient perspective. Using these requirements, the next step is to construct the framework of what we call the asks and tells. What are the things that we're going to tell the patient? And what are the things that we're going to ask the patient, including confirmation of key points? This is the straw man of the conversation. These templates and guides, as I said, are on GitHub. So we have a process for documenting the objective of the conversation and to document the asks and the tells. And from the straw man we have put together, the dialogue is written and then coded up into NLP, which will include things like dialogue navigators, such as repeats, conversation breaks. Somebody needs to have a break to go to the bathroom, for example, that needs to be coded in. Conversational ends and handoffs to staff for follow-ups. So the guided conversation interaction also enables hospital staff to assess the readmission risks. The other benefit of this conversation is starting to make the patient aware of what they need to do when they get home. A critical approach to designing conversations is to apply design principles and patterns for specialisation, localisation, and standardisation. The reason for this is that randomness and bespoke doesn't scale, and from the patient's perspective, avoids confusion. In the example here about rehab, there could be a standard response about the benefits of rehab and why it's important, encouraging patients to participate in rehab, and we have written a conversation on this. Specialisation would be about what's involved in cardiac rehab specifically, or cancer rehab specifically. The core standard answer would be applied to both, which is easier to scale, but specialisation would drive additional benefits. Localisation is also a variation, and an example here might be about a local process. How do I get into cardiac rehab at this particular hospital, for example? There's an important point to be made also about language as a variation. There is commentary that with using translation tools, avatars can be made to talk 100 languages. So the digital human health coach is not a talking brochure. And so from co-design perspective, this is not an automatic process. A conversation is about more than words. And from a patient perspective, context is critical. Even in English, there are highly local words, idioms, and local foods and so forth. And we have built the corpus with a great many of these synonyms already. But keeping front of mind the health outcomes and that these conversations are mostly with health illiterate populations. Health illiteracy is across all cultures. Literal translation would be problematic. The fundamental principle of co-design, nothing about me without me, really means that a co-design effort for an English-speaking community cannot be a cut and paste by simply adding translation. However, applying the design principles of standardisation, specialisation, localisation maximises the reuse of this pattern. In identifying common patterns of conversations, there are common parts of processes to which conversations can be applied. This modular approach maximises reuse. This illustration, how design principles of standardisation and modularity can maximise reuse of a guided conversation across health domains and processes. For example, there is commonality across the process of admission. We also emphasise the importance of using pre-existing content, such as videos, as part of conversations. There are a great many heart health videos out there. Some are very useful, some are not, at least for the health illiterate populations. Problematically, most videos are buried deep in websites where they're very difficult to find. And this means that patients and carers who might benefit from them will never find them or see them. A guided conversation or corpus answer to a question can include a short relevant video and of course images to convey information in a way that is easier for patients and their carers to understand and to maintain interest. This approach, rather than dumping videos onto websites, allows videos to be presented in context and to be published on GitHub. Work in progress, 10 guided conversations, including the heart failure conversation that we just worked through, with instructions and templates to build your own. So I've spent some time talking about the patient experience, the patient journey and patterns of conversation, design principles for localization, standardization and specialization, reuse and modularity, and a new thinking about the impact of healthy literacy on machine learning. And the purpose for providing that background is to show the depth of structure that goes into the development of the corpus to achieve natural contextual conversations that are linked to health outcomes. This is the dimension of the corpus that will be published on GitHub. Extensive spreadsheets, actual content, co-designed guided conversations, tools, accelerators, and development notes. From the corpus development perspective, this is how the Q&A patterns and guided conversations come together. Through research resources, professional health forums, patient forums, peer-reviewed research, books, websites, university lectures, rehab programs of varying types, advocacy and patient groups. And from this, we created a repository of thousands of questions and question patterns and a database of synonyms. Patients often use different words to mean the same thing, including variations in specificity. For example, they might say the word drug, or they might say statin, or they might say Lipitor, depending on their level of literacy. So we have accommodated word variations by using synonyms and have developed hundreds of these specific to cardiac health questions. In this example, we see a common concern that is a medication is giving a patient a symptom or a side effect, regardless of whether this is a concern about cardiac or oncology. So here we see a common pattern of a question with a synonym that can apply across different health domains, which means that this method readily scales. And instead of relying on a patient then to ask the next question or knowing what to ask, the question can trigger a guided conversation. So we need to think about the corpus as not just a massive database of everything, but a structured essentially on three patterns of content that have different purposes. Created content specific to the digital human health coach, which is new content. Collated content, which already exists, and this is domain-specific content, and with collation brings context. And curated content, such as videos and maps, which adds further richness to the conversation. So this is a model of patterns of content that can be the core of conversations across different health domains, accommodating variations for localization and specialization across the patient journey, from in-hospital to the cliff I spoke about earlier, and beyond to thriving every day, linking to curated content and ecosystems. As with Nadia, we envisaged the digital human cardiac coach to be omni-channel, and this means that conversations could be accessed via many channels and interfaces. For example, if we think about Alexa or Siri or Google or other conversation assistants, or through smart home sensors or virtual worlds such as Second Life. Essentially, it is the same corpus supporting conversations and interactions across these different interfaces. So let's look at how our digital human cardiac coach patient number one, Alan, uses various ecosystems. And this is becoming the norm. Just imagine what this would look like in the decades ahead. And we really need to be thinking about ecosystems and how these ecosystems can be used and can become a natural part of telehealth. Obviously, far more is needed beyond the phone and video that we rely on today. And over the next couple of slides, I will show how conversations guided by a digital human can be used to capture measurements and other data, initially not requiring machine vision to do this, but providing a capability roadmap for this to happen. Just again emphasising that the technologies I'm talking about all exist and are in common use today. The US allows telehealth consults to capture and review physiologic measurements from patients. And I'll talk about these reimbursement codes shortly when I cover off business case dimensions. This allows for guided conversations about the importance of these measurements and can identify causes for non-compliance. Their scales are broken or they don't have a blood pressure monitor. So not all non-compliance is due to poor patient attitude. Educationalists and psychologists have an important role to play in the co-design of the digital human cardiac coach to ensure that understanding and willing participation is the norm. So in this example, we see the conversation with the digital human cardiac coach, reminding the patient to take their blood pressure. The patient simply reads back the numbers, no integration with the blood pressure device required. So here we see how the ecosystem gradually becomes part of the roadmap. As on the previous slide, conversation only for the recording of blood pressure, for example, then the use of the camera to take the photo of the readings on the blood pressure machine, and progressively the digital human guided conversation can incorporate screen capture with the Apple Health app, which is something that we use. The ecosystem approach and capabilities such as screen capture can really accelerate the adoption of telehealth, enabling specific and specified activities under the new US CMS reimbursement codes. The additional benefit of this is that screen capture enhances accessibility, reduces the impact of health illiteracy and physical impairment, deciphering, reading and inputting numbers. So I spoke about accessibility barriers early, forms, brochures, websites and so on. An ecosystem approach provides people with greater choice and optimises accessibility and provides for greater servicing innovation. This is our ecosystem and we are heavily dependent on the Apple ecosystem during emergencies and especially on those occasions. The Apple Health ecosystem has helped us and the paramedics and the ER doctors. But this approach is technology neutral. The conceptual architecture view of the ecosystem shows the various services increasingly become essential components of telehealth. Our vision is to have the corpus of heart health conversations accessible via this ecosystem, and we and others use these naturally every day. One capability of the digital human cardiac coach I'd like to highlight is machine vision, technology in use today. There is a lot of health information to understand, and we have seen with telehealth and data to communicate. And we have discussed different ways of doing this, not all of which require integration. One of the most common areas of difficulty is understanding meds. From a health literacy perspective and even physical accessibility perspective, reading and understanding a meds label is almost impossible, especially for people who are health illiterate, and that is most people. Machine vision can help overcome this. Using the machine vision capabilities with devices, an object database could readily be developed so that a patient can simply hold up their meds packet or bottle. The digital human health coach then recognises the object, including keywords, and explains in simple words to the patient what the meds are and to always see their doctor. No typing, no trying to get a person to try to read complex words, mostly printed in small font. The same approach can be used for the identification of letters and forms. The object of the digital human cardiac coach and the digital human health coach more broadly is overcoming the impact of health illiteracy and opening up perspectives on accessibility. So let's have a look at this further. And this is how we have interpreted the various digital services, platforms, ecosystems and environments, as these all have barriers impacting cardiac health outcomes and costs. Across this spectrum, there is a phenomenal innovation and R&D, essentially to build the knowledge and capacity of people. However, compounding structural problems that these all encounter is health illiteracy and numeracy, unmet demand for conversational support, resource rationing, and physical limitations. The research and work into avatars and virtual assistants in the healthcare environment shows incredible potential application. And shortly I'll talk further about the virtual world work at Mayo and the groundbreaking work at SimCoach. Most of these involve deep co-design, and the digital human cardiac coach does not replace these and other great tools or replace skilled humans. It augments them in a very unique way, and over time, as I said, connects to other features and content, such as maps and videos, and perhaps eventually to be able to give rehab lectures so that patients can ask questions and interact with the material at any time. Oh. Okay. So with health illiteracy and accessibility front of mind, this is an example of a question by a patient on a patient forum and an answer by a health professional. And this is a moderated patient forum. It demonstrates the significant challenge of health illiteracy. Patients who are health illiterate asking questions and health experts writing exam questions, answers in response. This is the same problem faced when there is no co-design of digital services, including apps, relying mainly on the health experts and professionals doing content writing. Expert, authoritative answers does not make the information more intelligible. So what we are faced with here is a completely different set of skills. And this is the same challenge facing machine learning. So surely a chatbot can help write, and I'm going to step through these slides progressively. I did have a video, but the video took a little bit of time. So this is Sam, the chatbot, on the Health Government website. And what we see here is effectively a poor replica for search. Minor typos affect the answer you receive, a real issue for people who have difficulty with keyboards. So we see nested websites, frenzies of links, and incomprehensible answers that are spilled out. It assumes that people have very high levels of literacy and endless time. None of this is accessible, none of this is conversational, and none of this is natural. So what started out as a simple question about pizzas results in the person being referred to the suicide prevention hotline. The intent was totally lost at a time in their life when they are most traumatised, not co-designed, not conversational, not accessible. So let's look at the difference between digital humans, virtual assistants, and chatbots. Digital humans are not chatbots, but embodied, empathetic, intelligent digital beings with a co-designed personality, defined roles, and a deep body of subject matter knowledge, capable of having contextual conversations, not just simple chit-chat. Digital humans like Nadia and the digital human cardiac coach are not a Siri or an Alexa, answering questions on any topic from the general population. These are bounded systems, co-designed to have contextual conversations. I'm going to go through these next few slides fairly quickly, and this is about virtual worlds. So imagine being able to interact with others in a virtual world of government servicing or healthcare servicing, helping others and getting help from others. This is what we had envisaged in the Nadia project. We explored what was happening in the gaming world and virtual worlds such as Second Life, where virtual beings and avatars are engaged in conversations. And many people with disability are avid gamers. They say they can be whoever they want to be and are not judged. And so from this insight, Nadia was to have a presence in Second Life, to be where the people are. And it was also envisaged that in Second Life, people would be able to have their own avatars, taking on roles such as mentor and connector. The role of these conversations and peer guidance was seen as an important and new way to build capacity and similarly for the digital human cardiac coach or health coach to also have a presence in a virtual world such as Second Life, focused on health illiteracy and new models for access to cardiac health information and services. And this is already happening in healthcare and therapeutic settings in the United States with peer-reviewed evaluations. This information is on GitHub. SimCoach is a virtual human used for monitoring for signs of PTSD in service personnel and veterans. And in the Nadia project, we researched this in extensive detail. SimCoach was co-designed with a cross-section of people, including veterans. The clinical evaluation of the SimCoach program has shown that this embodied virtual human establishes rapport with the veterans it is interacting with, and together with anonymity, creates therapeutic alignment, resulting in higher levels of disclosure, which means that supports can be more timely and more appropriate. So the digital human health coach is designed to be omni-channel, but this is not just about a website, but including virtual worlds that we've just discussed. So let's look at some perspectives on the design of the architecture. So this really gets under the covers. If you buy a digital human face, you don't get a digital human cardiac coach or a digital human health coach. And that's because that's only one component. This deconstructed model is technology neutral, and there are many digital human offerings and technologies with different capabilities. Similarly, there are many AI platforms, and there is a lot of phenomenal work and research actually which is accelerating. However, it is the digital human health coach model with a focus on co-design, the operating model and corpus, which we have seen, which brings this to life, making it more than the sum of its parts. And this is a conceptual architecture of the digital human health coach as an omni-channel capability governed by co-design, focused on health illiteracy, accessibility and choice. Co-design deeply shaped the architecture through and across channels. Literacy, cognitive ability and accessibility are design determinants, which are not only important for people with disability, but for everyone. And I'd like to add that the digital human health coach contemplates input from all types to support accessibility, haptic input, signing, brain patterns by neuroswitch. These haven't been developed yet, but the conceptual architecture envisages it. So we really need to open up our thinking about accessibility beyond websites and apps. Another way of looking at this is through analogy. A Formula One car literally has a driver at the centre. And think of this as high performance accessibility. Why should healthcare be any different? The modular design, the chassis, the engine and tyres, and importantly, the data analytics are an integrated blueprint, just like the digital human health coach conceptual architecture. The Formula One car is not the sum of its part, but rather a holistic, intelligent blueprint. So the digital human health coach model can be considered as a blueprint of capabilities. These capabilities drive different but complementary benefits for patients and the health system. And shortly I'll show how these benefits translate into hard numbers. I'm going to step through these slides again fairly quickly, given time. I might just go through to the business case. So I've been doing business cases for a long time now, and I have to say this one is the most exciting business case I have done. In this COVID period, we have seen how fragile the current face-to-face servicing models are. But there have been market trends emerging for some time, and we need to see the pressure and the opportunity in a different way. Accenture forecasts that in just a few short years, the AI-powered virtual nursing assistant market would grow to $20 billion of value, helping to meet the growing gap in the health workforce. This equation cannot be solved with more dollars or more people. COVID has proved that. But innovation in servicing models and changes to policy and reimbursement codes establishes a more resilient future posture. So let's have a look at how the new US Centre for Medicare and Medicaid Services reimbursement codes might drive innovation in remote monitoring and telehealth services across the patient journey. In this example, over 30, 60, 90 days for the purposes of avoiding unplanned readmissions over this period. The important thing here to understand is that the digital human platform is a suite of capabilities, not just the digital human face, and that these capabilities are omni-channel, which is why the architecture shown earlier is so important, where defined activities such as virtual check-ins and remote monitoring can trigger reimbursement. While these are US codes, a similar mapping could be done against reimbursement codes in other countries. And there are a number of key dimensions to a business case. In addition to the additional revenue from reimbursement codes, there are other qualitative and quantitative benefits, two in particular which hit the bottom line. To minimise Medicare penalties, this is a particular policy in the US, but it is likely that other countries are also looking at readmission and other performance penalties. Minimise litigation costs. In the US, a very significant factor in medical malpractice litigation is poor communication. Ongoing reinforcement and support will assist information transference, which is a significant challenge for patients and their families who are health illiterate. And this is how we see the architecture of an ecosystem, enabling architecture, enabling those telehealth processes and mapping to the new US CMS reimbursement codes. Remember, this is a model designed from the perspective of health illiteracy. The whole operating model has to be understood, and this is a content-rich, AI-enabled operating model. So these are the key dimensions of the business case, the burning platform, which was the pre-COVID world. But due to COVID, with cardiac rehab being suspended worldwide, there is real urgency to build scale and resilience. But that cannot be done by simply adding more resources, even if that was ever possible. Just putting up here a few new areas of policy and research, ethics, legal, contract. So in summary, the health coach model is a new and unique capability in healthcare, and it is a technology neutral blueprint. But we're not talking about the digital human face. It is the corpus of heart health conversations connected to outcomes in an omni-channel environment, co-designed to meet the diversity of people's needs. For the first time, this is a body of knowledge that describes a way to address the impact of health illiteracy on machine learning, and co-design is essential. The centrality of the corpus and the corpus concepts I've spoken about today. Think about omni-channel, think high performance accessibility, and co-design is essential. A summary of the material on GitHub, which will be released in the next day or so. You will see a document, read this first. I would suggest everybody reads that first. It's an explanation compendium of everything else, and keep an eye out on LinkedIn and Twitter. Many thank yous, which I won't go all through today. But our journey started in March 2006 when Alan was on a 20-kilometre run in an isolated snow-covered canyon in the high altitude near Winnemucca, Nevada, when he first went into problems. Our lives were irreversibly changed, but not for the worst. And these are some of the amazing people on our journeys. So now we pass the baton to everyone on this call. We hope that this helps democratise the work that we have done, and everybody can take it forward. Thank you.
Thank you. Mary, can you hear me okay?
Yeah.
Okay. Well, thank you so much. As Mary said, she was really going into a deep dive there. It's just fascinating, the amount of work, content, and the fact that Mary has basically provided this to everyone on the call, and really anyone who wants to access this through GitHub is absolutely amazing. I want to take a slightly different approach and talk about how this actually was embodied in an actual health system, how we took the baton, as Mary would say, and ran with it, and just tell that story a little bit for the purposes of anyone on the call who's interested in taking this information and actually trying to make it work, because it's a lot of stuff. As Mary said, she's been working on this for, I don't know, I didn't do the math, but 20 years or so. And it's one thing having 20 years of work. It's another thing when that work is evolving so rapidly. So let's just start off by just setting the scene. And one of the things I'm hoping to get out of this whole event is collaboration. So anyone on the call who's interested in collaborating with us in North Carolina, please get in contact with me, and Mary and I are going to be working together on this probably till the day we die, I think, because there's a lot of work to be done and we need as much help as we can to move it forward. So I'm speaking from North Carolina, from New Hanover County, down there in the southeast corner of North Carolina, in a little town called Wilmington. Wilmington's become very famous recently in my house because my wife is watching Outlander season 4, which tells the true story of the Scottish settlement of Wilmington, North Carolina. And they did a pretty good job at recreating Market Street and Front Street down there. So if you want to know what Wilmington's like, the Cape Fear River, just have a look at season 4 of Wilmington. That's a little bit of, tomfoolery, throwing in some TV there. But actually, as you'll see, as I go through the presentation, that Hollywood, movies, TV, games, all of these creative arts are absolutely critically important as part of the evolution of digital humans. And we'll come back to that in a moment. The environment here, where we find ourselves in Wilmington, North Carolina, is actually a really wonderful, beautiful area, very popular tourist destination. At least 3 beaches. I don't know how many. I've been here 18 months. There's probably 6 world-class beaches here. It's a real tourist destination. It's a growing area with interesting industries exploding here, such as contract research and other things, artificial intelligence and sort of more high-tech, really growing exponentially, I would say here. We're also got a very fastly growing retirement population. Up until recently, we were one of the top destinations for the retiring CEOs from Fortune 500 companies. So it's a strange mix of tourists, academics. We've got the world's largest military base not far from us here in North Carolina. Very, very diverse community. And slam bang in the middle of that is New Hanover Regional Medical Center. In terms of scale, it's probably standard mid-size health system. Many different facilities, all the usual expertise you would expect: cancer center, heart center, women and children's, orthopedic hospital, all the usual, rehab hospital. We also cover all of the emergency services for a pretty large region, actually. So we've got the helicopters and the ambulances, and if you dial 911 here in the United States, you're going to get a New Hanover member of staff coming to your home. If you look at all of our services, like specialties like cancer, etc., we probably service around 9 counties around New Hanover. Some people have said we do have a bit of a monopoly here, which is wonderful in the sense that, we are able to understand our community really well, but we do have to be careful that we pay attention to all of the other things that are happening in healthcare, and we certainly don't rest on our laurels. We are the 3rd largest county-owned hospital system in the US, which actually means that we're probably, a pretty good target for a for-profit hospital who would like to come in and snap us up. And that's, if anyone's interested about that story, you can Google New Hanover Regional Medical Center and news, and you'll find out what's happening in that state of events. But really where we are is very diverse community, very diverse people. We've got normal mix of ages, mix of races here, everything from American Indians, as one of our counties has the Lumbee tribe, very high content of Lumbee American Indians there. We have a higher than average number of African Americans, and all of the usual ethnic groups that you might see. Our poverty levels are a little bit higher than the average in the US, and I'll come back to that in a moment. Interestingly, from the perspective of the digital human cardiac coach, we do have you know, the same literacy issues that we see around the world. Health literacy notwithstanding, just standard literacy, 1 in 5 adults in the US, you know, have some level of standard illiteracy. 43 million adults in the US possess low literacy skills. And in one county, which is you know, I've selected just for an extreme, 27% of adults in Duplin County in North Carolina lack basic literacy skills. So the reason I highlight that is we really do have to look at new ways to transfer information to patients who have, as Mary said, not just health literacy skills, but simple literacy skills. And when you take someone who's educated, like Al and Mary described that, it's hard enough to be educated in engineering and you know, all the other levels of education and understand healthcare, never mind just having basic literacy skills. So we've got a real challenge that we have to address. Also in North Carolina, again, in line with other states in the United States and across the world, we're seeing a shortage of primary care physicians. And this is putting quite intense burden on the health systems across the country. When I arrived in Wilmington about 18 months ago, really this was my mantra. And it's not my quote, but I kind of lived by it in my previous roles. So that health systems that are not AI, virtual, and digitally enabled will ultimately be replaced by those that are. And really, when I arrived here, again, New Hanover Regional Medical Center is very similar to most hospitals in the United States who are really struggling with how to move from what is essentially a fee-for-service business model to a value-based business reimbursement model that really we have no choice but to explore. And that's because patients expect to be treated as consumers now. They see it everywhere else in their life. Amazon allows them to instantly acquire and consume whatever they really want. And, you know, same-day delivery of healthcare is a long way off. But really, we are starting to think about what's called the Copernicus moment, when we realize that the world doesn't revolve around the health system, but actually it revolves around the patient. And so New Hanover are very, very aware of that and working hard in our consumer development. And it really was in that context of this diverse population, this health system struggle, what every health system in the country is struggling with, where I first heard Mary talk about digital humans. It was at one of the Global Network of Health Innovation Center presentations, a webinar similar to this. And during the webinar, I connected with Mary and said, look, we really could use your help in what we're trying to achieve here. And really that was a turning point for me, certainly. Just to give you a feel for where that was in time, about 15 months ago, and we've moved a long way in 15 months. That was when some of you on the line may know Lucy in England and other colleagues, Zaina Kaya, another one in Toronto, who were really looking at redesigning the healthcare system from the perspective of the patient, including redesigning the whole hospital for well care rather than sick care, and then redesigning the home for sick care rather than well care. So that it became this blurred line between where is the place of delivery for healthcare? Is it the home? Is it the hospital? Is it the shopping mall? Or is it your pharmacy? And 15 months ago, this was just beginning to explode. We were seeing the first discussions around, is it possible to build a whole hospital that was 100% digital. And this is Shafi Ahmed in the UK, who was advising the Bolivian government in an attempt to build the world's first digital hospital. At the same time, many of the giants, Microsoft, Google, Apple, Mary talked about in her presentation, I was very interested in companies like NVIDIA, who were really 15 months ago just exploding into healthcare and really having a massive impact. A lesser impact, but I think ultimately will be equally significant, is companies like Magic Leap, who were looking at different types of virtual, augmented, and other types of reality using spectacles. And many people on the call will be aware that there's a lot of speculation that Apple's next big product's probably going to be something like that. But 15 months ago, these things were just beginning to really explode. In the hospital, we already had an interest in user interfaces. We actually have some patents on using the Alexa software. Siri was obviously around, not very useful if you were Scottish. She's getting better, to be fair, but 15 months ago it was very, very difficult. Gaming, and just the quality of imagery in gaming, and also the business models around gaming, were really, really beginning to have massive impact. I mentioned Fortnite on purpose because the company that makes Fortnite, the largest game known to humanity at this point in time, is just up the road from us here in Cary, North Carolina. I also want to talk about Hollywood a little bit, because what I hadn't mentioned when I mentioned about the environment in Wilmington is that we're actually home to the third largest movie studio in the country, and this is just some of the things that were filmed here. So when I met Mary and she was describing the digital human, it really fitted into a kind of master plan that I was creating here in Wilmington. Was how can I leverage these skill sets? We've got this amazing, probably the most influential games company in the world at this point here in North Carolina. We've got the third largest movie studio here. We've got our own film festival, and we've got a University of North Carolina, Wilmington, which has really grown up around these assets and has created a number of different programs in the creative arts and in things like AI and virtual reality, etc., that really gave us a unique opportunity to leverage it. There was a high percentage of skill sets here who, when they weren't making movies and making games, were available to work on things like digital humans. And it struck me that this was a real opportunity. So we also had a need. So that was kind of my real kind of master plan to leverage our assets. But North Carolina is ultimately a rural, it's got urban centers in Raleigh and Charlotte, and a few others, but mostly, as you can see from this map, rural. And we knew that telemedicine and digital health really, held a lot of promise if we could really use it well. That came really to the forefront during Hurricane Florence. Record-breaking storm surge. It sat over Wilmington, direct hit on Wrightsville Beach on the month I arrived here, and sat here for like a week. There's still people I know who still aren't in their homes following Florence. And what it really made us realize was telemedicine, telehealth, digital health is so important at times of dire need. It wasn't just that patients couldn't get to their physicians, but the physicians couldn't get to the physicians. No one could move. We were in a real difficult situation. And of course, we'll touch in a moment on COVID and how that has created a similar situation. Fast forward to today, though, when you look at the top 10 challenges of all the health systems in the United States, this is a poll that's done every year, we really see three that I think directly impact or directly point to the development of digital humans as a really important move forward in healthcare. First of all, the consumer experience, we've touched on that. People want to have access to healthcare and healthcare advice when they want it. They don't want to have to wade through websites. They'd like to just be able to ask someone and have an answer. The move towards a much more holistic individual healthcare, each of us want that, and you see that with our healthcare apps and our Apple Watches. We want much more personalized care and accessibility, which was always an issue, but it's really, you know, these are the top 10 challenges for healthcare executives in the United States. At the same time, when you look at the top 10 breakthrough technologies that are occurring right now in 2020, hyper-personalized medicine is right up there in the top 10. And I believe, you know, personally that we're at a convergence of problem space and solution space. And that's where magic usually happens. And I think digital humans are going to be right slap bang there. So that's really the background of what got me into this field in the first place. Really, everything I've done has been under Mary's watchful eye. One day I'll buy you a bottle of scotch or something to repay you, some sort of 100-year-old scotch or something. She doesn't drink, so I know I'll never have to do that, and I'm Scottish, so it's perfect. But really, when we actually started to develop it for real, it was Mary, and she touched on this in her own slides. Mary really helped us look at the situation here in Wilmington and put together the business case for us right here in our hospital. The analysis of how many surgeries we had, how many cardiac procedures we had, how we could take actual data and calculate a real potential saving if we had a digital human in place. Mary touched on things like the CMS codes and how we could save from penalties that we have that are a burden due to things like readmission, etc. And as Mary's already touched on, we know that health illiteracy and things like non-compliance with medication and care plans lead to readmissions and therefore lead to these penalties. So Mary really helped us put together the business case here. I think it was really important at that point, and Mary advised us to do this, but it really made a difference. And there's a shout out here to some of the key people, but we really worked for a while to get buy-in. And again, I leveraged Mary's expertise and sort of world-class reputation to ask her to speak to our leadership team, and she came over and spoke to the executive board here, and you know, described Nadia and what she'd done, and was really able to buy, for me, executive buy-in, and even to the level of the board of the hospital, where recently I was presenting to them, and at the very first question was, what's happening with Hannah? And so that was wonderful, because you can see from the top down within the hospital system, people had really bought into what we were trying to achieve. Critically within the cardiology field, and definitely hats off to Dr. John Rommel, who basically gave us the go-ahead to develop this. Janet DeLuca, Jeff Sukup, Dora Daughtry, and Rachel Hayworth, just a shout out to those guys for really driving this forward for us. Then we wanted to really make sure we got community buy-in. So we would do things like, we held an event within the local museum where we had 200, I think, people from the community, just people who may be a patient one day, but just people who we wanted to be opinion leaders, we wanted them to know who Hannah was and to just take it out there to the community. And again, Mary was very helpful there and presented at our film festival, Cucaloris. And then the wider community buy-in, I think it was important. Again, this webinar is part of that. We want collaboration, and we want collaboration from wherever we can find it, whether it's in Ireland or in Australia or in Shanghai. And Mary presented in San Diego Exponential Medicine. It was very well received and has been very, very helpful for us here. So the next step was to put together the team, multidisciplinary team. We definitely wanted quality and safety. I'm going to touch on that if we have a chance later when I have a chat with Mary about things like risk. But you know, safety is always an issue. Whenever you're using new technology, you've got to be very aware of the impact on the actual patient care. So the team sort of consisted of the innovation group, IT, of course, quality and safety, project management, and just massive support from nursing. I want to just say that one of the side effects of this, and any of you guys on the call who are considering getting into digital humans and you haven't really done it yet, you'll find that there's all sorts of side effects occur. One of the ones here was we had engaged an expert in human experience, human engagement, to really help us make sure that we didn't impose during the process of co-design. Of course, the whole point is this co-design doesn't allow you to do it. But we became aware of things like our electronic health records and just various other technologies that were by imposing technology on the system, we really created a whole load of human experience issues. And so Tina Abraham, who's our expert, created this concept, this business concept of Stay Human, which would create products that would allow new technologies, or companies wanting to launch new technologies into the market, would allow them to test it against a set of criteria. And so that was just one of these interesting side effects that came out of this project. We then, again, using Mari's guidance, and this is the type of content that Mari will be placing on GitHub, we were able to design a pilot. Really, the operating model, again, I won't go into the details that Mari's already covered, but the operating model, the governance, the co-design, we really were able to do that from the guidance and the content that is now going to be made available to everyone. We originally wanted to create two conversations. One, a sort of basic discharge process following the cardiac rehab, and then secondly, one around medications. Ultimately, we decided the amount of work involved in focusing on a single conversation for, a hospital system that had never done this before was sufficient for us at the time. And we held our first focus group meeting with patients in February, on February 28th. And really, we were looking forward to creating 3 separate teams to look at different aspects of the digital human as we moved forward. Then COVID hit, and we were really early off the blocks with COVID. NHRMC, I'm proud to say, essentially went into pre-COVID mode very early. Everything from making sure we had enough PPE to ensuring that we had all sorts of contingency plans for whatever might come next. But what did happen with COVID and what we're seeing now is it really did change a lot of things. One of the things that changed was this issue of reimbursement that we touched on earlier around digital health and telemedicine. And these are just some figures. Cleveland Clinic completed during March, single month during COVID, over 60,000 telemedicine visits, when previously to that it had been just over 3,000. Similar data with Jefferson Health System. And really what this says is people were really embracing what they could do digitally. And you can only imagine what we could have done if we'd had a fully functional digital health cardiac coach at that time. There's now a call to really, the barriers that were removed that allow us to do all of that telehealth during COVID, and we're still in COVID now. There's really a call now to say, look, these should remain, and I'm hoping they will, because if one of these lasting impacts of COVID is global adoption of telemedicine and the abolition of all of those restrictions that were put on, certainly within the US system, then really we're going to have an open door for where we could go with the digital human as we move forward. So where we are now is we're resetting. We're beginning to just slowly ease back into what we hope is post-COVID. And I just want to finish by just saying, in the 15 months since Mari darkened my doorstep, and really changed my trajectory as an innovator, we've seen a lot. This is a slide from that I really borrowed from NVIDIA's presentation recently, where they, along the bottom there, these are the AI companies that are all now working on conversational AI. And this is to Mari's point that really we're in a place now where we weren't 15 months ago, where we're going to see much, much faster development of a number of different types of AI. NVIDIA launched just, I think it was last week, their Jarvis platform, which is really pretty staggering in terms of what it can do in terms of conversational AI. And really anyone interested in digital humans really has to pay attention to what NVIDIA is doing. Again, I'm repeating what Mary said, but the idea of using a proprietary, this is Hannah in the top left, you saw images of her before, but you'll see similar, exactly the same face being used in various other projects around the world now, because it's a proprietary face. We really are in a situation now where the localization part of Mary's model is really open to many talented artists, designers, graphic designers, artificial intelligence companies to create very, very specific, almost personalized avatars for use within these digital human coaches. We have these, ultra, deep fake. This is from the This Person Does Not Exist website today. As you know, every day they put on a new created human that does not exist. These could be coming, we're beginning to see these being the mobility of the face being manipulated so that they can talk and speak and emote. I was blown away by the work that was done to recreate Martin Luther King. If you haven't seen it, and again, this presentation will be available to you, check out the work that was done and the quality and how they did everything from map blood flow to make this thing accurate. And this is moving so fast. So just to finish then, I think that we're, in the last 15 months, we are seeing the work that Mary started with Nadia and that we just touched on, just beginning to touch on with Hannah. We're seeing it really democratize, demonetize and dematerialize, as we see with all these exponential technologies. I think that the three components of the digital human coach that we're developing here in New Hanover, the AI is really going to be available for collaborators to come and say, hey, why don't you try our platform? We could really help you do that. And please come and talk to us if that's something you're interested in. The interface, as I mentioned, is going to be hyper-localized to Southeast North Carolina. We want accent that fits here. We want a number of avatars that suit all of our community, African American, white, Native American, Indians. And I just want to close by saying that I do believe that Mary is right, that the corpus, what Mary calls the corpus, that's really the sweet spot right now. That's where the work really has to be done. That's where we have an opportunity now to create intellectual assets, essentially, that given an AI and given an interface will open up a whole new world of opportunities. So I'm just going to close by saying, Mary touched on digital twins. Of course, they're very well known in industry. They're beginning to be well known in entertainment. And just as a closing throwaway that, human digital twins they exist now in a very kind of prototype form, but we are going to start to explore what it might look like if you were to essentially clone, Mary touched on that in her presentation, one of our clinicians, and specifically one of our neurologists who's very interested in looking at what would that look like if you had a bounded technology, critically that we say that, a bounded technology that Mary explained in her presentation, and we're able to use that bounded technology so that a single physician could essentially 24 hours a day interact with her patients through a digital human clinical clone. I'm going to stop there, and Mary, I know we're going to open it up. I'm going to stop sharing and hand back to you. This is just to say, I don't know if we're on the edge of a precipice hanging on by our fingertips, or what this is going to do to healthcare. Thanks so much for listening.
Chris, that was absolutely phenomenal. And this sense of being on the precipice, it's uncomfortable for most people. But I think what we've seen, and what a lot of people see, that that's where innovation happens. I would say collaborate, contact Chris, have a look at the information. when it's up on GitHub, apply it. The reason why we started with cardiac was not only obviously because of our own circumstances, but it's a universal body of knowledge. It's not like it's specific to a particular, government program. It's a universal body of knowledge, and that makes it highly replicable. So just over to you, Chris.
Yeah, and I mean, I would echo that, absolutely, the collaboration, but also please share among your wider network the idea that there's certainly this process of that we've talked about now, the AI, the interface, the corpus. That's absolutely critical in terms of the engine of what we're doing. But what every day is a learning when you're in this world. And what we need is also collaboration around other areas. For example, where if you know a lawyer who's interested in intellectual asset management, we are challenged with who owns the creation of the AI, who owns. We're challenged with if you're aware of spiritual leaders who are embroiled in ethics and morality. We have questions around privacy, cybersecurity. Blockchain is obviously, we didn't have a chance to touch on it, but blockchain is obviously a critical component in terms of the conversations. Some people might be aware that the Supreme Court in the US recently said that they would accept a blockchain set of data as legally binding, that they accept the fact that blockchain cannot be disputed. So you could imagine a blockchain conversation and what that would do when someone couldn't say, well, no one told me that. So there's a number of areas around ethics. And one thing I just wanted to throw back to you, Mary, is obviously any hospital system, there's different types of risk. The most important risk is the risk to the patients. Clearly, that's the priority and paramount. And so risk is always a difficult thing to measure. And as you release digital humans, it's like releasing any piece of software or any medical device. And of course, the FDA.
That's one of the reasons why democratizing it was the only way to go, because the issues are very significant and the space is moving so quickly.